Good morning, everyone, and good afternoon to anyone tuning in from the East Coast. Thank you for joining us today. My name is Marisol Aviña, and I am the Director of Public Affairs at the California Endowment. And it is my great pleasure to welcome all of you to today's policy webinar, Tracking the Diversity of the Health Workforce, Findings from a New Study. This is the first installment of a two-part series on the recently released report from the George Washington Fitzhugh Mullan Institute for Health Workforce Equity, titled The Race and Ethnicity of the California Health Workforce. As a health foundation, the California Endowment is interested in the transformation of the health system to an equity-focused system that advances racial equity, and we recognize that workforce is key. For a state as diverse as California, it is critical to have a workforce that reflects the rich racial, ethnic, gender, sexual orientation, and cultural diversity of our communities. We supported the commissioning of this report, and we are very excited to share the findings with all of you. And we are very much looking forward to learning from this conversation and this amazing lineup of panelists and speakers that we have prepared for you today. A couple of logistics and announcements before we get started. One, we encourage you all to engage in the conversation by posting your questions in the chat, as we will have two opportunities during the program for Q&A. Also, we will be sharing the slides after the webinar with everyone that registered. And lastly, I want to note that TCE's policy webinars are intended to be nonpartisan and non-lobbying informational sessions. All right, so now on to the program. It is my great pleasure to introduce Dr. Joanne Spetz, who will be facilitating today's webinar. Dr. Spetz is director at the Philip R. Lee Institute for Health Policy Studies at the University of California, San Francisco. She is an internationally known expert on the nursing workforce, leading studies of nurse supply, demand, education, earnings, and contributions to the quality of care across healthcare settings. Her research focuses on the economics of the healthcare workforce, organization of healthcare services, and quality of healthcare. She also directs the federally funded UCSF Health Workforce Research Center on Long-Term Care and teaches health economics and finance at the UCSF UC Berkeley Masters in Translational Medicine program. Okay, so now over to you, Dr. Spetz.
Thank you so much, and it's a pleasure to be here. For those of you who were not familiar with the California Future Health Workforce Commission, their work finished several years ago, and their report was a culmination of a statewide 2-year effort to address California's healthcare workforce issues. Equity was a centerpiece of the vision of that report, and among other goals, the Commission's bold recommendations seek to provide Californians from all backgrounds and communities opportunities to excel in the health professions. So the report that we're going to be presenting today and reflecting on today is from George Washington University, as has been mentioned, and it provides a really detailed picture of the diversity of California's health workforce, revealing, not surprisingly, that there is a lot of work to be done. So we have a great panel for you today. We're going to begin with a presentation of the report's findings from Mr. Salzberg, from Edward Salzberg, who is the co-director of Health Workforce Diversity at the George Washington University Mullan Institute. He has been a national leader in health workforce research, policies, and data for over 25 years. I've known him for much of that time, and he has always been an inspiration to those of us who do work in this area. So he's currently on the faculty at George Washington University and has successfully established and managed in the past 3 health workforce research centers. So he'll be presenting his work, and then we have a respondent panel that I'll introduce now. We have Juan Carlos Bayard, and he is the Assistant Vice President for Community Partnerships and a professor in global health at the School of Public Health, Loma Linda University. He has a PhD from Claremont Graduate University, and he teaches in the areas of culture and health, traditional and complementary and alternative medicine, ethnographic research methods, health disparities, and other areas. He's very involved in initiatives to strengthen community-university relationships and will be one of our panelists today. Our second panelist is Leandra Clark-Harvey. She is the CEO of the California Council of Community Behavioral Health Agencies. She is a psychologist and has this organization that she leads represents mental health and substance use disorder nonprofit agencies that collectively serve over 750,000 Californians annually. She also is the executive director of the California Access Coalition, which is a group of advocacy organizations and pharmaceutical industry companies that advocate for patient access to behavioral health treatment. Finally, our third panelist is Ross Lallion. He is the research section chief of the Healthcare Workforce Development branch in the California Department of Healthcare Access and Information, which was previously the Office of Statewide Health Planning and Development. Within HCI, he has been in this leadership role for nearly 6 years, but he has been at the organization for quite some time. And he has conducted research to understand health workforce disparities, health equity issues, and health workforce data needs. So with those introductions of our panel, I would like to hand it over to Ed Salzberg to tell us about this really important research that he recently completed to kick off our discussion today.
Great. Thank you so much, Joanne. I really appreciate the introduction. I should note that I've had the pleasure and opportunity to work with folks at the UCSF Health Workforce Center and UC and others in California over the years. And it's really an honor to be able to present the data today on health workforce diversity in California. As you know, we issued a report recently, the Race and Ethnicity of the California Health Workforce. And today, my goal is to present some of the key findings along with sharing information in terms of exactly what is in the report. Next slide. I should start out by noting this was really a team effort, and we have a great team of researchers here at the Mullan Institute and the Beyond Flexner Alliance. And I want to start off by thanking the California Endowment and the Josiah Macy Jr. Foundation for their support for our work on the Health Workforce Diversity Initiative and this report. Next, please. A word about the Fitzhugh Mullan Institute for Health Workforce Equity. Fitz dedicated his life to issues around equity and health workforce, and it's fitting that we name the Institute for Health Workforce Equity, because we are really trying to bridge and identify and focus attention on the fact that the health workforce is really critical to an equitable healthcare system and addressing health disparities. Next slide. So, not surprising, the problem is well known. On a wide array of health indicators, Black, Hispanic, and Native Americans have lower health status than white people, and that these disparities are well documented and have multiple causes. We also know that Black and Hispanic and Native American individuals are underrepresented in the health professions, and we strongly believe that by increasing diversity of the health workforce, we can take a step towards improving health equity and addressing disparities. The basic approach to the problem of the Mullan Institute and the Health Workforce Diversity Initiative is to regularly publish data on race ethnicity representation, particularly in the educational pipeline, to promote transparency and accountability. Next slide. We think there's a real audience for the diversity data. State and local policymakers really need to have this information to understand how well they are doing in their communities in terms of diversity. And this data can really help drive policy. Second, academic leaders are critical. It's really important for academic leaders to understand how well is their institution doing in terms of producing a diverse health workforce. Third, the health professions organizations. Health professions have a responsibility to take actions to promote a more diverse health workforce. Health delivery systems have a clear interest. If they're serving a diverse population, they really need to have a diverse workforce. And advocates, and I really want to stress the importance of this data to advocates. At every school, in every institution, there are individuals who will support and work towards a more diverse workforce, and providing them with the data and information is really critical. And then finally, the media is interested in knowing, and they're aware of the topic, and providing them with hard data really promotes the cause of those committed to increasing health workforce diversity. Next. So we are fortunate in this nation to have two major sources of data that in the public domain, federal data that is readily available. The first is the American Community Survey. The second is the Integrated Post-Secondary Education Data System. Most of the data I will present today are from these two public sources of data. We cover in our report the diversity of 25 health professions, and we look at the pipeline in 21 healthcare professions. And I'll go into this more as we go through the presentation. Next. This is a summary of the sections of the report, and we covered data, basically taking the health workforce diversity data and looking at it from a number of angles, and I'll very quickly run through each of these sections. Next. Ooh, hit the next one too. Okay, go back one. For some reason, it's not showing up. I want to be clear about the diversity index. For the diversity index, we compare the diversity of the workforce or the diversity of the graduates to the diversity of the population. If the diversity of the graduates is equal to the diversity of the pipeline, and we define that as the population 20 through 35, then we'd say the diversity index is 1. And the example I use here is from real data. This is actually the existing workforce in California from the American Community Survey 2015 through 19, which had that 38% of the labor force in California were Hispanic, but 19% of the PA graduates were Hispanic. That would give us a diversity index of 0.5. Next slide. The diversity index is really important because if you want to compare how is a California doing, how is a school doing in graduating a representation in among Black individuals and among Hispanic individuals or Asian individuals, the denominator is really different. So it's important to use the diversity index to see how well you're doing in a particular race, ethnicity group or state or profession. I want to be clear, this is data from the American Community Survey, and it's important to note that in California between 2015 and 19, 38% of the population workforce between 20 and 65 were Hispanic. So I want you to keep in mind that's what we use as the denominator when we do the diversity index for the current workforce. If you look at the population age 20 to 35, 43% of the California population was Hispanic. So when we look at the diversity index and look at how well is California doing in terms of Hispanic graduates, we compare that to the 43% of the population who were 20 to 35. We chose 20 to 35 because we're looking at health professions that can be entered with a 2-year degree, a 4-year degree, or a doctorate. So we say in general, the graduates are between 20 and 35. So that's what we chose as the denominator for the diversity index. Next slide. So the first set of data I want to present is the workforce. Next slide. So what you see here is on the existing workforce, and the report covers 25 professions. The bars on the right that are blue are the health diagnosing and treating professions. The purple are behavioral health professions. The green are allied health professions and technical positions. And then yellow are support staff positions. So the red bar is the parity. The red bar in this case is 38%. We're looking at the Hispanic representation in individual professions. And what you can see is just how far, particularly for the health diagnosing professions, and the representation of Hispanics are compared to, in terms of that red line. Not surprising, in terms of the support staff, in the orangish lines, Hispanics are well represented in most of those professions. Just to note some of the numbers that come out in this figure is that Hispanic workers, comprising 38% of the labor force, represent only 7% of the physicians, 8% of the dentists, and 3% of the pharmacists. Next slide. This slide compares the diversity of California and using the diversity index, the diversity in terms of Hispanics in California. And if you look at the little stars, little triangles, that's where the national diversity index is. So one of the things that is apparent in this particular figure is that all of the professions that require a doctorate, the California is doing less well compared to the rest of the nation. Again, you can see that other than the support service occupations, Hispanics are not anywhere near well represented or equal representation as they are in the population. Next slide. The report also presents the diversity and the diversity index and the representation by major community. Now, in order to have a minimum number of people to make it statistically relevant, we had to group different regions of California. What you see on the map are the regions that we grouped together. It's important to do this because the reality is clearly that the diversity of the baseline population is quite different in different parts of California. So you want to, again, adjust when you do the diversity index for the diversity of the base population. What you see here, looking at the Hispanic population, they're not well represented in the professions requiring higher education any place in California. But again, this allows someone to look at their community or at least their region in California to see how well they're doing. Next slide. We also have a section where we look at Hispanic and Asian subpopulations. As you know, much of the data that gets reported in a lot of our data systems only goes down to Hispanic population or Asian population or Black African American population and does not delve down into the subpopulations. In the report, we provide some important data by the different subpopulations. For the Hispanic populations, we look at Mexican, Central American, South American, and then Caribbean and other. Let me take a moment to comment on the color scheme, because this color scheme in the report is really helpful in identifying who's doing well and who's not doing well. So what that scale is, it's a scale of the diversity index where the darker the red is the lower the diversity index, going all the way, getting lighter until it's green or gray, which is and gray is above 1 in terms of the parity. So you see how, in this case, how poor the diversity, how limited the diversity is in terms of Mexican Americans. Next slide. This slide, the data table, shows the representation of the Asian subpopulations. And one of the things that became apparent as we did this report was Asian people, while they're generally well represented in most of the professions, when you look at the behavioral health professions, regardless of the Asian subpopulation, all of them were less underrepresented in the behavioral health professions with the diversity index below parity. Next slide. So I'm going to talk about the pipeline next, which is really the educational. Next slide, please. So this one, again, with the Hispanic graduates, and what you see here is we actually have 21 professions. The yellow bar, we've now added public health. Because public health is not a single profession, after people graduate school, we could not easily identify the diversity of the public health workforce, but we can identify the diversity of the graduates of the public health programs. What you see here is that while Hispanics are doing well in 2 of the behavioral health professions, they are still well below parity in these 21 different, in the 19 other health professions. Next slide. I also wanted to show how well Black individuals do in terms of graduation in these 21 professions. And what you see here is Black graduates are relatively well represented in most of the behavioral health professions, but with the exception of advanced practice nurses, Black African-American graduates are clearly very underrepresented in individual professions. If you go to the report, you can see the specific data on each of these professions. Next, please. Also in this section, the report on the diversity of Native American graduates. And as you can see, in the majority of the diagnosing and treating professions, Native Americans are underrepresented. And again, somewhat surprisingly, they are not underrepresented in the behavioral health professions among the graduates in California. Next slide, please. This particular section shows the change in the diversity of the graduates between 2010-12 and 2017-19. And this particular figure is for Hispanics. What you see is that Hispanics in all, except for PAs, the percentage of graduates who are Hispanics has increased over that period of time. So that's encouraging. Next slide. This slide compares the diversity of the graduates to with the diversity index to the diversity of the pipeline nationally. And again, what we see here is when you compare the professions that require a doctorate, that California's diversity in terms of Hispanic graduates is less than the national. Even in the other professions where the diversity in California as the diversity index is better than the nation, I would not say that it was adequate diversity. It's still well below parity with the exception of the 2 behavioral health professions. Next slide. This slide is an important slide. This slide compares the diversity index for the graduates compared to the diversity of the existing workforce. The graduates of a profession represent the future. Typically in a profession, maybe 3 or 4% of the profession may retire in a year and 3 or 4% new people come in. So the new people, the graduates, the pipeline, you want to be more diverse in terms of the populations in California than the existing workforce. So what this slide shows is, again, pretty much with the exception of PAs, the diversity of the inflow, the pipeline, the workforce coming in is more diverse than the existing workforce. I would say that's encouraging, but then if you look at the actual data, you see just how far we have to go. And we have an enormous way to go in terms of coming any place close to parity, particularly for the Hispanic population. Next slide. This next section, next slide, is really important. The report actually has the diversity of the graduates of every health professions program in California between 2017, using data from 2017 to 19. And again, the color coding is really important. So what you see is the dark red is the lowest quintile in terms of less than 0.2, with parity being 1. So none of the medical schools come close to having adequate representation of Hispanics compared to the Hispanic in the pipeline age group of 20 to 35. Next. This is the graduates in dental schools and pharmacy. And again, you can compare the performance of individual schools, and the color coding quickly tells you that almost all the schools are at the bottom level in terms of the extent of diversity in terms of Hispanics. The report includes the data for Hispanics, Blacks, and Asian Americans. Next slide. Um, this is just a summary for the nursing programs. And here you see, yes, there are programs in nursing where they are again, we stayed with Hispanics on this slide. There are schools that are above parity in terms of the Hispanic graduates, where they graduate a higher percent of Hispanic than the 43% for the pipeline denominator. Next slide. So in conclusion, three main points I want to make here. As I've said throughout the presentation, Hispanics are really very underrepresented in the health professions. While there is some encouraging signs that their representation is higher in the pipeline, for the most part, California and the schools in California have a long way to go to coming any place close to parity for the Hispanic population. There's documentation in the report that shows that Black and Native American populations are also underrepresented, although not to the extent of the Hispanic population. But in 76 of the 600 programs we looked at, in 76 of 600 programs, there were no Black graduates, and 372 had no Native American graduates. And again, another important finding is that Asian Americans are underrepresented in the behavioral health professions, both in terms of the workforce and in terms of the pipeline. Next slide. Some takeaway messages. I think this data and the report provides valuable information that the state, that the educational institution, and that advocates can use. First, you can look at the schools that have been doing well and try and find out from them, what are they doing? What's their formula for success? Second, and this is really important for the poor performers, I think the community and the advocates need to ask the college presidents, the leaders, their boards of directors of the university, the deans and program directors, what more can they do? Particularly those at the bottom of the scale. Why is it that your school is doing so much lower or has so much less diversity than other schools? California needs to clearly consider additional programs and initiatives targeted to underrepresented minorities. I want to stress, I think, how important it is to monitor trends and compare across institutions, states, and professions, so that people can ask the right questions in understanding where are they at in terms of health workforce diversity. And finally, I recommend the HCI, the state licensure boards, and the University of California to consider collecting additional race ethnicity data. I should note that one of the limitations, while the IPEDS data is really fabulous in giving us good data standardized across institution across the country, the reporting is about a 2-year lag. And if you think about that, I showed you the medical school graduates from 2017 to 19, they were medical students who started 4 years earlier, so 2013 through 2017. So the question is, has anything happened since this data? So I really urge the state or actors in the state to consider collecting data on diversity of applicants, of admissions, as well as graduates and faculty. I want to encourage institutions to take action to increase diversity, and I don't think we want to have to wait years and years to know about whether their efforts are being successful. So data on acceptances would be really helpful, and I think it's worth thinking about where can you get that data. And then finally, if one is collecting diversity data, it's important to think about other aspects of diversity. This report focuses on race ethnicity, but clearly there are other demographic factors that people are interested in knowing about representation. So if there is an effort to increase data collection around diversity, I urge consideration of a variety of other demographic factors. Last slide. If you have any questions, please feel free to email me at esalzberg@gwu.edu, And please visit the diversity tracker and the California report. And the website is here, and we will be sending out, I believe the California Endowment will be sending out a follow-up information where you can access the report. Thank you very much.
Thank you, Ed, for presenting that. And I appreciate those recommendations. I do want to note that the California Board of Registered Nursing has been collecting data on the diversity of admitted students for well over a decade. UCSF is the contractor to the State Board of Registered Nursing and has been collecting those data. So at least we have it for one profession in California. So there's a question that came in the YouTube chat. People to place questions there. But this one I want to give to you, Ed, before we get the full panel discussion going. Your data went through 2019, and there's some recent data from California that indicates that during the pandemic, there have been declines in post-secondary enrollments in California, particularly for the community colleges. I'm interested in your thoughts about what implications that might have for some of the progress that you reported towards improving the diversity of our workforce if we see some losses in the community college enrollments.
I think community colleges have been a really important avenue for underrepresented minorities and low-income individuals. And so I think a decrease in admissions and graduates at community college will be a setback in terms of diversity. I'm hoping that with as the pandemic, as we come out of the pandemic, that enrollment will pop up. My understanding it is not yet, but I think it is really an issue of concern. If you look at your variety of options and I believe the subject of the second webinar in this series will be about possible initiatives and policies to address underrepresentation. I think support for community colleges is really an important one. And Joanne, the fact that California collects data on acceptances in nursing is a really excellent opportunity to assess whether there's been improvement since the 2017-2019 data became available. The 2020 data is available, but that's still a lag in terms of knowing whether schools have been more successful in recruiting a diverse student body.
Great. So we have another question that came in from the YouTube viewers. Have similar studies been done in other states besides California?
Good question. I'm not sure. I do know that we have published data at the national level, and we actually have an online tracker that pretty much has much of this data, where you can actually hone in on a particular state or a particular institution and get the information on the data on the diversity of their graduates by profession. I should say at this point, the diversity tracker, the online tracker, only has the 10 health diagnosing and treating professions, and only has data on Hispanic, Black, African American, and white individuals. But over the next 6 months, we are planning to increase the professions covered as well as the race ethnicity groups covered.
Great. So I'm going to give you one last question from our YouTube viewers before we go to the panel. So this question is really about the pipeline investment. And the question is, do the pipeline issues really start at the K through 12 level, and what kinds of parent and child intervention approaches or strategies that you know of that have been successful to help bring people into considering the health workforce occupations?
So I think the question raises an important question and issue. Clearly, if individuals and race ethnicity groups are not graduating high school or college at the same rate, they're disadvantaged to begin with. And so I think an investment in K through 12 is absolutely essential. But I would not suggest that only relying on the investment at K through 12 would be sufficient to lead us to a more diverse health professions group. I think the investment in STEM education and orienting children to STEM, particularly Hispanic and Black students in inner city schools and economically disadvantaged communities, would be an important step forward. And I think, again, goes to one of the root challenges that we have, that we don't have enough underrepresented minorities in the STEM professions. And again, investing in K through 12 is part of the overall strategy that I would recommend a community consider.
Great. Thank you so much, Ed, for that great overview of the report findings. And so now let's go ahead and transition to the panel. So let's see, looks like we lost Joanne. So if we could bring up Juan Carlos and Leandra and Ross. And thank you again so much for joining us this afternoon, or this morning and afternoon on the East Coast. And one of the first questions that we had was just your initial reactions to this data, and if you wanted to share some of that with the audience, that would be amazing. And Joanne, welcome back.
Thank you. I don't know what happened to my internet, but there you have it. Let's see. So thank you, Marisol, for asking that first lightning question. Let's begin with Juan Carlos. What struck you most about this report's key findings?
Well, first of all, thank you for this opportunity. Great report, Ed. Just to give you context, I'm actually sitting here at home looking at where the rest of my family is working at the hospital, like 2 blocks away. So my wife's a physical therapist, my daughter's an occupational therapist, and our son's in medical school. So you can imagine the kind of conversations we've had around this report right here in our home. But I think one of the things that that really stood out was just the disparities between, if you look at that blue section of the diagnosing and treating professions, and you were to put a salary, a median salary to them, those are the high earning professions. They're also the decision-making professions. You're diagnosing, you're treating, you're making decisions in healthcare. So that's where the power really lies in healthcare. And it's not lost on me that the power is not equally shared across the different racial and ethnic groups. The point about Mexican Americans being even more underrepresented in California was a bit shocking to me, and it made me think about the nuances of the data. And I think Ed talked about those subpopulations and how important it is to look at the subpopulations and also ask ourselves, why are Mexican Americans in California underrepresented when they're overrepresented in population, not just in the healthcare workforce? And I think about also the difference between diversity, which is great, and equity and inclusion, and why we need all of those, and not just having diverse graduating classes, because many of those classes, the diversity is representing first-generation immigrant students, and you can look at populations like in the Black population. If you just use Black as a demographic, then it could be, I think of our medical students. Many of the leadership and the representation come from Caribbean or African families, very few African American. So the question to me is, the longer that your family has been in the country, the more difficult it is to be part of these professions where the power and the finances are. And then finally, just the breakdown of the regions was very eye-opening. I'm in the Inland Empire, and we have a lot of work to do here. So just wanted to open with those comments.
Thank you. Leandra, what struck you most about the report's key findings?
Well, I really appreciate the comments by my colleague around power differentials and acculturation, because I think that's real. And if we look at things along those lines, the data tends to kind of fall out very differently. But, you know, as it pertains to workforce, we already had cracks in the system prior to the report, right? And prior to the pandemic. And now I feel like we have craters. And our safety net, you know, in many ways is no longer a net. It's now a series of dangling ropes. And our providers are really trying to catch clients on a tightrope walking above them. And I think that's why it's so important to really focus on efforts like the report did around reflecting what's being done to sustain the pipeline, but we also need to focus more on how to build it. And there were some comments about working with younger populations and starting education about behavioral health careers and pathways earlier on, which is really important. And I know the state is working on that, but that's an area where traditionally research and efforts haven't been really focused enough on, even with the report. So I think that there's definitely opportunity there, especially since we're experiencing this pandemic. Loan repayment and stipends are great, but we really have to focus more at the beginning of that pipeline. And I think we have to catch individuals really early as we expose them and educate them about careers in behavioral health, pathways, etc. Also, I think there's a great opportunity to utilize unlicensed professionals. It takes a long time to create a physician, a psychologist. I went to school many years, as did my colleagues. And so in the meantime, we need to utilize the workforce that is at hand. And there are individuals with lived experience. There is a new movement now, and now there's going to be a new certification in our state around peers. We can use community health workers, promotores. How do we really integrate and build out that team so that folks are able to access healthcare in any ways, in any space, at any time? It really is going to we're really going to need to utilize a team approach to make that happen. Also, I'd like to see a greater focus on substance use disorders. You know, we focus a lot on mental health, right? And clinicians, and there's drill down around there. But when we're talking about behavioral health, it really is comprised of mental health and substance use disorder, you know, licensed and unlicensed professionals. And so more focus there, more data collected there, because that's an area where people can more easily enter the field through getting a certification, shorter degree programs. And I think there's a lot of people with lived experience that can add to our integrated care teams, particularly for behavioral health. And the last piece, if I had my wish list, I would love to see more focus on older adults. That is a population that we haven't been giving enough attention. And California has started to focus on this more. The governor has his master plan for aging and other efforts to collect data and to, you know, put into play various different, you know, projects and looking at how older adults are aging and how they're aging well. So how can we utilize our older adults as they return to the workforce as well? Those are some other areas that I think the report could have focused on, and I just think there's more focus that's needed in terms of growth there.
Great. All right. So now we'll turn to Ross for our last first kind of lightning round question of what struck you most about the report's key findings.
Thank you. I think the team did a phenomenal job on the study, especially considering the data limitations and workforce data that we have in California. There's sample size limitations, not being able to track our graduates, among other issues. So I'm looking forward to our conversation today about how we as a state can improve on some of those data-related issues. And I also think about, you know, the workforce data is kind of one piece of this puzzle. How else can we integrate workforce data with other data, poverty data, substance use abuse data, and things of that nature to really build up the pipeline? I think workforce data is an important piece, but this is one piece, right? And some other key findings, there was 76 health professions had 0 Black graduates. That this can't happen. That was kind of eye-opening. Our Hispanic population is underrepresented by a wide margin in all diagnosing and treating professions. And I think while Hispanic representation in the pipelines rose for almost all professions, it's a positive step. In certain professions, that gap is still way too large. I think dentists, physicians, psychologists, among other professions come to mind. I think an important consideration for us is that the diversity index or the representation of our Hispanic population, that's probably going to continue to grow. So we need to capitalize on progress that we're making, but really kind of accelerate that progress. As pointed out in this study, Hispanic and Black graduates are underrepresented in almost all health professions requiring that post-secondary education.
Great, thank you. You know, I know that California is now through the HCI working on ways to develop more robust data to strengthen our ability to collect equity-related information and data in general about our health workforce. So Ross, maybe you can go into a little more information about some of these efforts, and perhaps including some of your thoughts about unlicensed professions. As Leandra mentioned, that workforce being a key component of our health workforce overall, and also potentially a pipeline. If you can talk on kind of where your efforts are and some of the pathways you might see it going.
Absolutely. Thank you for that question. So we at HCI, we're really excited right now because we're setting up the California Health Workforce Research Data Center. So the purpose of this research data center is to be a central repository for health workforce data in our state. So what that means is that we want to collect data, consistent data throughout the health workforce. The types of data we want to collect include data on the supply and demand of the workforce, geographical distribution, diversity, the educational capacity to produce the health workforce. So I think the state, we at HCI recognize the need to create this central repository to really collect consistent, high quality data, then really to include all health workforce disciplines, right? Like our licensed providers, certified providers, but also those unlicensed, uncertified folks. So we're thinking about kind of the scope of collecting data across all health workforce disciplines is really large. But without this holistic view, we may miss out on key insights. For example, the study did a great job on the kind of comparing, excuse me, the racial and ethnic diversity of diagnosing and treating providers versus healthcare support. So we want these data coming out of our research data center to inform our stakeholders, to inform state health workforce policy. So it's essential for us to make these data easy to access and to collect high quality data. I think one of our first goals is to develop a baseline minimum set of data collection throughout the health workforce. We're starting with our licensed providers in terms of collecting this minimum data set. And much of this data we're collecting is based on HRSA's minimum data set, but it does go beyond that. We're collecting really important demographic data that's going to strengthen our ability to assess equity issues. So data on race, ethnicity, language is spoken, sexual orientation, gender identity, educational background, et cetera. And I think so for this data collection effort for our licensed professionals, what we're collecting is prescribed in statute. So for those that are interested, the variables are included in Business and Professions Code 502. But we have future goals to kind of expand this and collect this similar data set for a certified health workforce, but also for those unlicensed, uncertified health workers. And I think, for that piece, it's going to take a really collaborative effort. The state can really kind of lead this effort, but I think our stakeholders on the ground at the regional level, we're really going to have to take this team approach to collect those data. I think demand data is also really important to this effort, as is educational data. I think educational data is absolutely critical to this effort. Understand the pipeline and some of our foundational issues. So our short term is to leverage some of the public education data. I think beyond that, we're looking forward to working with our educational institutions to bring in some other valuable data sources. And so I think the state's leading this effort to create this central repository, but it's really going to take that collaborative effort to make this thing a success.
Great, thanks. Leandra, I would like to ask you to react to that. Given that HCI and Ross's team and his colleagues there are in the early stages of putting this all together, what do you want to put on your wish list for them to think about collecting? What kind of additional information would you like to see?
That's a really big question. I could spend an hour talking about that. I think that, again, the report did a really great job, right? And you have to start somewhere. And I do think that if the report was to be expanded, I'd love to see more about, despite some of the efforts to drill down on certain Asian Pacific Islander populations, there's really room for improvement, as this category it's incredibly diverse, as I think was acknowledged earlier. There really needs to be an accounting for the differences, especially around socioeconomic status. And I really think that is the key indicator there, that all the data is going to fall out a little bit differently around. If we had $1 million to do it and expand it, also, I think if there was an opportunity to recruit more Native American participants, I think there's a lot missing there in terms of their experience and the diversity among those that may live on tribal reservations and lands, those that are more. So I think that acculturation is a big part of this that has to be accounted for. And I think we'll learn so much more about the diversity of the workforce, who's ready to enter, where they're at, and how that all falls out across socioeconomic status and acculturation. Also, I think if there was an opportunity to examine clinicians that are bilingual, their experiences, where they end up working, what types of populations they end up working with as well, I think back to working in children's hospitals and the differences amongst our team, and versus folks that may have been bilingual and able to serve other populations as well. Their experiences were different. So I think a way to capture that would be really amazing. And then again, more focus on the unlicensed professionals, of course. So peers, community health workers, promotoras, etc. They are ready to assist, and there's ways to integrate them again into the workforce in a way that can be helpful, not just to our workforce and getting more bodies out there, but getting folks that have experience, understand, and have a reality around cultural competence. And I think it's important to clients too to see themselves and people in their community reflected in their healthcare team as well. So I think there's lots of opportunities to expand, collect data, especially in this workforce crisis that we're experiencing right now.
Thanks, Leandra. Juan Carlos, I don't want to leave you out. What are some additional data items you might put on your wish list for us to understand better the diversity of our workforce and its capacity to meet California's needs?
I think a lot has been said, and I agree with everything, all the recommendations. Maybe just to add to that would be tracking folks who are moving up the career ladder. Say they start out as a respiratory therapist and then go to medicine, or start out in nursing and do medicine or pharmacy. These are career ladders that we've seen can be very effective, and I think tracking that would be helpful. Also, I think even expanding the denominator beyond the workforce, because I know just within the Inland Empire, our percentage of disconnected youth, and the term applies for youth, I think it's 16 to 25 years old, who are neither working or in school. That's 16% for our region. So we're not really taking into account the folks who are not in the workforce and who represent a significant part of our population as well. So those are the two things that I would recommend adding.
Thank you. So, I want to toss a third lightning round question out there for all of you. And then I think we'll bring Ed back in to join us. And I'll start with JC. You had mentioned and kind of pointed out the Inland Empire. And of course, you've also mentioned that even in your own family, you're kind of your own model pipeline in your family in the health workforce. We have very big differences region to region in California. If you took our state and flipped it over and laid it on the East Coast, it's New Jersey to South Carolina in terms of diversity and the geographic range that we cover. Where do you see are some of the important ways to think about the intersection between the regional differentials that we're seeing in shortages in general and the diversity? So, JC, I'll start with you, and then Leandra can perhaps speak to the intersection between the regional differences and the diversity issues and ways that we might tackle that from both a data standpoint and some of the underlying policy issues to keep in mind.
Well, I think there are some things that are very specific to each region, and that will require different strategies. But there are also lessons learned and things that have worked well in some regions that can be adopted in others. But everything that's been suggested as far as bolstering the K through 12 on the early side of the pipelines, but then also having a welcoming environment in the training, in the universities and the programs that we have in colleges and universities. So there's supporting structures. I know there's an increasing number of minority serving institutions across the state and the country, but they must go beyond minority enrolling institutions and really serve those students with the structures that are needed for many of them who are first generation students and who will struggle navigating the complexities of higher education. So it's really a comprehensive approach, both on the early part of that pipeline and also on the training and then the integration into the workforce.
Great. Leandra, additional thoughts about the intersection between the regional differences and the diversity issues?
It's really interesting, so I'm a psychologist. I trained in the Midwest. I worked in the Midwest before coming to California to continue my training. And so thinking across those training settings, I also grew up in the Inland Empire and practiced in an inner city, right? So thinking about all of those different training environments is really interesting and important to me. I wanted to come back to California. I'm from here, and I had an opportunity to come here and continue my postdoc and residency and everything. And I think sometimes we assume that rural areas are going to be, really different. Inner cities might have, all of these resources and professionals. Everyone wants to come to the big cities, but working in inner cities, working in more rural parts of the state, while the populations might have looked a little different, a lot of the needs were similar. And so I know that that's interesting in California because we have this beautiful, diverse landscape, and all communities are different. But when it comes to behavioral health needs, there's a lot of commonality there, and there's ways that we can utilize existing workforce that's within those communities. One thing that I know is really difficult is working to be able to attract professionals to certain areas, and that's where you see some of the differences in terms of rural communities, right? And so the ability to bring in physicians for their training and retain them, I think, is an issue that we need to continue to look at. So stipends and loans are great, but there has to be more than that, right? Loan repayments, wonderful. Stipends are good for a while. I received some stipends that were wonderful and helped me. But in terms of, really bolstering the workforce and keeping them in place in the areas that they're serving and a part of the public behavioral health system, there have to be other incentives. There has to be help really with housing, there has to be help with at a place that there's a community where you want to raise your children, where's a good, school district. So it really is all the social determinants of health working together, even when folks are highly educated, to attract them to an area, to keep them there so that they continue to grow that area and really grow the fiber of the workforce there. So there's lots of, different issues that I've pointed out, but I think it's important to take all of those things into consideration when we're developing programs. It's not good enough to just throw, stipends or loan repayments, because when that runs out, people will often leave the area. They'll leave after their training program. So I think more attention there around the different communities, and then being careful about our assumptions too that we're making about rural versus urban and the needs that exist.
Thanks. So last, we don't want to let Ross out on this for this last question about the intersection between region and diversity. Perhaps you can talk a little bit about what you anticipate to see in the HCI data, especially because we know there are a lot of people who commute fairly long distances across regions in California, or might serve in multiple regions, and the potential for data to address those kinds of issues.
Yeah, absolutely. I really appreciate these comments because I think it is a comprehensive approach. Excuse me. I think loan repayments and stipends, scholarships, they have their place, but we have to take a step back and look at what issues are really, what's other roadblocks, like childcare, housing, transportation, things of those nature, and then really, I think integrating our HCI data, the really rich workforce data we're expecting to get, with other types of data to understand those issues, and then supporting those issues, right? And I think at HCI we're kind of taking a step back. And, we're still supporting those traditional kind of interventions and programs and loan repayments, stipends, scholarships, but really focusing on effective pipeline programs, for example. The rural pipeline versus urban, they might be different, but I think a lot of the issues are going to be similar. So really focusing on those. And then the other things like childcare, that I think is really big. We hear that from our stakeholders all the time. Housing, so that's huge. Transportation is really big. So I think there's a lot of other issues, and we're looking forward at HCI to integrating our data with other data, really enrich our analysis and understanding of different workforce issues.
Great. So now we are really ready to bring Ed back into our space here. He's been around, but we'll bring him back onto the screen. And I would love to see some of your questions for those of you in our audience. You can put your questions into the YouTube chat, and we will be moderating those and asking all of our panelists, including Ed, whatever questions you might have around, around this report or any of the other comments that have been made. So one question that I will kick off with that I see in here is, I think both Ed and then maybe Ross can follow up with it, about measuring and tracking unlicensed professionals. Licensed professionals are comparatively easy to get information about because you have a licensing list, whereas unlicensed workers are much harder to track down. So Ed, what have you seen nationally on strategies to do that, and what data that we have and how we might be able to bolster those data? And then Ross, I'd love your reflections on that as well.
Very tough question. There's some information we get from national sample surveys like the American Community Survey, but they're not at the individual level. So you can get a little bit of data, again, from the American Community Survey about non-licensed individuals in California. But I think what you're really interested in is knowing more about the individual. And you identified the key challenge, Joanne. When someone is licensed, the state has a record of that individual. They have to apply for the license. They track them, and they have to renew their license periodically. But if it's an unlicensed individual, then there may not be any central database. Now, some states may have require registration, which allows them to at least have a name and identify a person who's in that occupation. So that's something to consider. Obviously, this has to be balanced out with public perceptions of state information about individuals and privacy. But I think it's totally appropriate for the state to have at least some basic information on anyone who's providing care. So one needs to look more closely than I have at the state information systems, the state regulation and data set on individuals, even if they're unlicensed. Again, I think it's really valuable that the state have some information, even if you don't require a formal license to practice in a profession. I don't know if Ross has other ideas in terms of his experience.
But that's spot on, Ed. I think, excuse me, without that structured kind of mechanism to collect data like we do for licensed health professionals is really challenging. I'm not going to sugarcoat it. It's tough to collect data. We have very limited data now. I think you made a really good point. I think there's a big outreach effort that's needed, right, to kind of get a hold of these folks and let them understand why we're collecting these data, why it's important, and why the state's even asking for this. I think it's a collaborative, kind of holistic approach with our stakeholders. But it is a lot more challenging because we don't have that structured mechanism to collect these data. But I think that communication and marketing outreach, I think, is really important to let folks understand why we're collecting these data, why it's important.
Yeah, so Ross, what is the timing of some of the data collection that you've been describing for us? What do you expect will be collected within whatever the short term is? And I'll let you define short term.
Sure.
And then when you think about the long term goals, what kind of timeline are you hoping that those data are achieved?
Yeah, so our licensure data collection is going to go live in July of this year. So that's kind of our first step. We're looking forward to that. So that's really short term. I think our next step might be with our certified workforce, because we have that mechanism in place while we kind of develop and understand ideas on how to collect unlicensed data. So we're hoping that's a relatively short term, maybe like by next year or so. So we need that holistic look at the health workforce. We need all different components of it. So that's one piece, and just a couple other pieces that are important. I think demand data is critical. I think hopefully that'll be our second generation. Then educational data, I just want to get away from that. I think educational data is absolutely critical. That's a big hole, I think, currently, if I'm being honest, about our health workforce data collection. So I think that's kind of a more medium and long-term goal that's absolutely critical. We have good public data. IPEDS data that was used for this study it's good. Although I think we're looking forward to working with our education institutions to be bringing even other valuable data sets.
Well, let me comment. One of the gaps in our data systems is as Ross mentioned, is about the graduates. And, other than medicine, because medicine has a comprehensive data set and physicians bill, and you can track them that way, most schools don't know, and the state certainly doesn't know, if the graduates of a particular program are staying in a state. And so I think it is in the state interest, and certainly in workforce planning interest, to know which schools are producing not only diverse graduates, but which schools are producing graduates who practice in California. What communities do they go to? I think designing a data system would really require the involvement of the educational institutions and the state licensure boards, perhaps, to identify what percentage of graduates of a school end up practicing in California. again, it's not only about diversity, but it's really understanding the commitment or the contribution of individual schools to the workforce in California.
Absolutely. I just want to make one comment. I think it's something else that would be really helpful for us, which I want to get to, I think, with the second, third generation of this research data center, is understanding who our providers are actually serving. I think in the study the study pointed this out. Currently, we're looking at our providers and then kind of looking at our population data, but really getting to who are the providers actually serving. That's next generation. I think that'd be really helpful with this analysis. Speaking of the next generation, I mean, we've been doing some studies using claims data, and where we're beginning to use Medicaid claims data. That's really important because the Medicaid claims data actually identifies the individual practitioner. And so you can trace that practitioner back to where they went to school and ask the question, and particularly if you have a comprehensive data set on the physicians or the PAs or the dentists, are the people who are licensed here, who's providing services to people on Medicaid and in underserved areas. So there's a lot. I think the next generation of data would involve combining some of that licensure data on demographic information along with claims data to see who's actually providing services to high need populations. You can do the same with Medicare, who's providing care to the Medicare population. So there's a lot of potential. Mm-hmm.
Yeah, so I have a question for Leandra. It's been mentioned that professional associations could be part of data collection as well. And I know you have an association of a lot of different individual providers and organizations that are in there. What do you see as opportunities perhaps for professional associations to either help with data collection directly or to help as champions of data collection, especially as long as these surveys are voluntary?
Yeah, I think it's a great question, and I think it answers itself in many ways, right? So I think schools are great captive places to get data. I've seen a lot of success there. I remember when I was working in Madison, Wisconsin, we had the community mental health center that I was working at partnered with the school district across the city to collect data on students, to provide services and referrals. And that was incredibly effective. And I think models like that are very, very important for services. But I think it's also a way to educate students. It's a way to track professionals who are working within school settings, whether they're doing their practicum or they're, school counselor or school psychologist. I think it's really going to take a collaborative approach and really piecing together a lot of different data sets across a lot of different environments, whether that be schools or, like you mentioned, professional associations like the one that I lead. We do have access to the behavioral health community-based organizations. They can let us know about the statistics around the staff that they're hiring, the clients that they're serving. So I do think that it really will take working with a variety of organizations, working with schools, some of those, institutions that are already set up. I think so often we're trying to think about a new way to do it, a new way to collect data, new places to go to creating. And I think sometimes we just have to look at what's already here and how to pull from that and maybe reformulate things in a way that is most helpful. It would be great if we had one repository, right? But I think in absence of that, we have to look at different settings, different organizations, schools, et cetera, to collect that data, to really paint a broader picture of what the workforce pipeline looks like in our state.
Great. We have a question that came in from our YouTube chat from Ariana Morales, and she asks that the disparities in the presentation seem far greater than what programs can tackle alone. How can higher education institutions be held accountable to address systemic barriers for students? Who wants to take a first tackle at that?
I'll comment. I'll comment on that. So let me note that the second webinar in the series on June 9th will focus on strategies to increase diversity. I agree that schools alone can't be held responsible. I mean, that's why the state is an important audience here. The state and cities and communities, the investment in K through 12, all are important. But there are things that schools should do, and that's why, I think the data that we present, which basically rank the schools, raised the question to go to the schools at the top of the ranking and say, what are you doing? and to go to the schools at the bottom of the ranking and say, what more can you do? Now, we did a paper, we published a paper on ranking the dental schools, and then we went and visited and did case studies of 5 schools that had improved significantly between the 2010-12 period and the 2017-19 period. We got some very valuable information about what was working for them. And I will tell you, one of the most important things was the commitment of the leadership of the school. If the university or the school is committed, then they were looking at a dozen different strategies, including the culture of the school, to try and make it in order to try and increase diversity. So yes, schools alone can't be held accountable, but again, they're part of the solution. And I believe that many schools can do more through a focused effort at increasing diversity.
I completely agree. And I actually think that that's where it begins. It really begins with access to education. And if schools are working hard to recruit a diverse student body, then it all kind of trickles down. And it's not just recruiting, it's also about retention efforts after you get folks in the door. What are you doing to support them? What type of mentorship are you providing them? And education is part of that process. In undergrad and grad school, I received a lot of training, mentorship. I was a McNair scholar. There were lots of programs that I was involved in that helped really sustain me and get me to my PhD. So it's not just about getting people in the door. It's not about just the presence of diversity, but it's around supporting folks and doing so in a way that's culturally competent. And I think that aids to creating professionals who really value cultural competence as they matriculate and go out into the field to provide service to lots of clients in need.
Just like Ed mentioned, leadership matters. I think explicit statements about diversity, in our mission, on our websites, in the way we present our institutions, but that really needs to translate also to diversity in faculty. And once you have a diverse faculty, recruiting underrepresented minority students is a lot easier. I know I've had students that have told me I was the first professor of color that they had their entire, college experience. And so I always ask, like, where did you go to school? But so I think that's part of it. The pipeline doesn't just end at college or these health profession programs. The pipeline needs to continue into faculty positions and administration positions of leadership, because that's where the real change is going to happen. And then just the question about how to grow our own, also, I think it's through partnerships. Higher ed, partnering with K through 12, connecting our minority students to kids in the community, I think is a powerful way of creating those role models for students who haven't had that. And I know here in San Bernardino, we have community vital signs at the county level. And one of the top priorities is the diversifying the healthcare professions and the workforce piece. So it's a very multi-sectoral approach of, how can we recruit, how can we provide internships, apprenticeship programs that will expose these students to what could be their future.
So I want to squeeze in one more question. I know we're getting close to the end of our time together. Chris Perrone asked, are low Medicaid rates for California physicians an impediment to the diversity of our physician workforce? On the diversity index, overall, how does California compare with states that have higher or greater parity between Medicaid and commercial payment rates?
So we haven't looked at that specific question, the relationship between Medicaid rates and diversity. I'm doubtful. I think the Medicaid rates may impact on willingness of some physicians to serve Medicaid population, but the pipeline is so long to become a physician. I think there are so many other factors that come into play, and we really need to again, I think, work to build the pipeline into medical school, into health professions, into medical school, and support underrepresented minorities through the medical education process. We do know from data that they're more likely to practice in underserved communities, and I believe also data that they're more likely to serve Medicaid. but I don't think the Medicaid rates alone would be influencing someone's career decision in terms of health professions in medicine.
All right. Well, we are now at 10:15, so I'm going to hand it back to Marisol to wrap us up and tell us about the next steps of this project in our second webinar.
Great. Thank you so much, Joanne, and a round of appreciations to Ed, Ross, Leandra, Juan Carlos, for your time today and for this very rich conversation. We appreciate each one of you. We learned a lot. And we are hoping that you all will join us to continue this conversation on June 9th at 9 in the morning. If you registered for the first webinar, you are registered for the second, so you will be receiving the link for the next webinar. And we also ask that you please fill out a survey that we'll be sending out to all of you in the next day or so. We love to get your feedback, and we also hope to see you again on June 9th at 9 in the morning to continue this conversation, to go deeper into the policy implications of this data. Thank you so much, and hope to see you again on June 9th. This concludes the program.